Welcome to Uniquely Spoken Podcast, empowering healthcare, where transparency sparks transformation. Are you ready to dive into conversations that will spark ideas and inspire action? This is a podcast that refuses to accept the status quo. Welcome back. This is episode 20. One more nurse or one more unit clerk. It's 5:47 p.m. on a 40-bed skilled nursing unit. Dinner trays are going out. 2 residents have call lights on. A family member is standing at the nurse's station asking about her father's new blood pressure pill. The phone rings. It's dialysis transport confirming tomorrow's pickup time. And Maria, the evening medication nurse, is holding a cup with 11 tablets in it, standing outside room 14, trying to remember which resident she was about to see before the last 3 interruptions. This scene repeats with small variations in nursing homes across the country every single evening. And when administrators ask what would actually make this safer, the answer they usually reach for is simple: hire another nurse. But what if the safest, most cost-effective fix isn't a nurse at all? What if it's someone who never touches a medication cart, a unit clerk, someone answering the phone, greeting the family member, processing the order, and protecting the nurse from constant interruption? Tonight, we're asking a question almost nobody in long-term care has examined directly. One more nurse or one more unit clerk? To understand why this question matters, we first need to understand what a medication pass actually looks like, not the version described in a job posting, the real version. Imagine a 30-bed unit with one licensed nurse responsible for residents taking 8 to 12 routine medications each, along with as-needed medications and complex treatment schedules. The nurse begins at 4 o'clock. Within minutes, a CNA reports a skin tear. A family member wants an update. A blood sugar reading requires a physician call. None of these interruptions are unusual. They are normal. Research consistently shows that interruptions occur during more than half of medication passes, and every interruption increases the risk of mistakes. The medication itself has not changed. What changes is the nurse's attention. The central question becomes, if interruptions are driving risk, what is the most effective way to reduce them? For the past several years, nursing home staffing has been at the center of a national debate. Federal regulators introduced minimum staffing standards that included a required amount of nursing care per resident per day and around-the-clock registered nurse coverage. Supporters argued the rule would improve resident safety and save lives. Operators argued the workforce simply did not exist to meet those requirements. Litigation followed. Congress intervened. Ultimately, the staffing mandates were repealed. But one important requirement remained. Every nursing home must still evaluate its residents and determine what staffing is necessary to keep them safe. That means administrators are still forced to answer a critical question. When resources are limited, where does the next hire produce the greatest benefit? A surprising part of the staffing debate involved licensed practical nurses. More than 170,000 LPNs work in nursing homes. Yet regulators concluded that LPN staffing did not show the same consistent statistical relationship with outcomes that was seen with registered nurses. As a result, LPN hours were treated differently under the staffing rule. Many nursing organizations strongly disagree. For our discussion, the controversy highlights something important. Not every additional nursing hour produces the same return. And if that's true within nursing roles, it raises an even bigger question. What is the value of a non-clinical support role that exists primarily to eliminate interruptions? Unit clerks do not appear in any federal nursing home staffing formula. They receive no staffing credit. They do not increase reported nursing hours, and yet they often handle the tasks that create the most disruption for nurses. Phones, visitors, order processing, scheduling, transportation coordination, chart organization. None of those tasks are direct clinical care, but all of them compete for a nurse's attention. The system measures clinical hours. It does not measure how protected those hours are from interruption. The research on interruptions is remarkably consistent. More interruptions lead to more medication errors. That finding appears again and again across healthcare settings. Researchers have also found that many interruptions during medication passes are administrative rather than clinical. Phone calls, family questions, paperwork, scheduling issues. The strongest evidence shows interruptions increase risk. The weaker part of the evidence is this: no major nursing home study has directly compared hiring one nurse versus hiring one unit clerk. So while the logic is compelling, the direct proof has not yet been produced. That distinction matters. The theory is promising, but it remains a theory that deserves further testing. Documentation consumes a substantial portion of a nurse's shift. Every order requires processing. Every incident requires documentation. Every admission generates paperwork. Many of these tasks involve clerical work rather than clinical judgment. A unit clerk can handle portions of that workload under established procedures. The nurse still verifies and approves clinical decisions, but the amount of typing, tracking, and coordination can be significantly reduced. The result is more time available for direct resident care. Consider 3 common sources of disruption: family communication, dialysis coordination, physician order processing. Each may appear minor in isolation. Together, they consume hours of nursing time. A family member wants an update. Transportation needs confirmation. A physician order arrives and must be routed appropriately. A unit clerk can manage much of the logistical work while escalating clinical questions to the nurse. The goal is not replacing nursing judgment. The goal is protecting it. Long-term care continues to face severe workforce shortages. Turnover remains high. Many nurses report that administrative burden contributes significantly to burnout. They entered healthcare to care for residents. Instead, many spend large portions of their day dealing with phones, paperwork, scheduling, and interruptions. A unit clerk targets exactly those frustrations. An additional nurse adds clinical capacity. A clerk reduces administrative burden. Which solution is better depends entirely on the actual problem the facility is experiencing. The strongest evidence supporting additional nursing staff involves hospitalizations. Facilities with higher registered nurse staffing levels generally show better outcomes and fewer hospital transfers. The argument is straightforward. More clinical expertise available on the unit can lead to earlier recognition of resident decline. The clerk argument is more indirect. Reducing interruptions may help nurses notice problems sooner, but that connection has not been directly proven. One relies on established evidence. The other relies on a reasonable but untested chain of logic. Imagine two similar nursing homes. One hires an additional nurse. The other hires a unit clerk. The facility that hires the nurse gains clinical capacity. Overtime may decline. Coverage improves. But interruption volume may remain largely unchanged. The facility that hires the clerk sees a different result. Phones are answered. Orders move faster. Documentation support improves. Interruptions decrease. But clinical coverage remains exactly the same. Neither choice is universally correct. Each solves a different problem. Let's review the evidence honestly. Strong evidence supports the relationship between interruptions and medication errors. Strong evidence supports the relationship between registered nurse staffing and resident outcomes. Strong evidence confirms that unit clerks are excluded from staffing formulas. Moderate evidence suggests administrative burden contributes to turnover. Moderate evidence suggests clerical support reduces documentation workload. The weakest area of evidence is the claim that hiring a unit clerk directly reduces medication errors in nursing homes. That remains an important hypothesis, but it has not yet been conclusively tested. Advocates argue that staffing minimums protect residents. Operators argue that flexibility is necessary because workforce shortages remain severe. Both sides agree on one thing. Facilities should assess their residents' needs and justify their staffing decisions. Interestingly, very little attention has been given to support roles like unit clerks. The debate has largely focused on nursing hours, while overlooking the interruptions that consume those hours. Every staffing decision has a cost. Most nursing homes operate with limited margins. An additional licensed nurse generally costs substantially more than a unit clerk. That financial reality forces administrators to make difficult decisions. When only one position can be added, the choice becomes more than a staffing decision. It becomes a strategic decision about what problem needs solving most urgently. The evidence does not support a universal answer. Facilities with adequate staffing but excessive interruptions may benefit from adding a unit clerk. Facilities with genuine clinical coverage shortages may benefit more from another nurse. The key is understanding the actual source of risk. Track interruptions, measure workload, study medication passes, diagnose before hiring. Because the real question was never nurse versus clerk. The real question is this: what stands between your staff and the task in front of them? Answer that honestly, and the hiring decision often becomes clear. I am Juanita, the founder of Uniquely Spoken LLC. I started this podcast to ignite change in healthcare, starting with long-term care settings. It is time to transform nursing homes and rehabilitation centers, assisted living and memory care communities to all become premier long-term care settings nationwide. It is time for all long-term care settings to receive a 5-star quality and customer service rating. It starts now, and it starts with me. It starts with you, and you. And the time is now. Thank you for joining us. We broadcast every Tuesday at 8:30 a.m. Eastern Standard Time. Don't forget to join the conversation, request to be a speaker, and partner in transforming long-term care settings. And don't forget to tune in next week. Thank you for joining us on Uniquely Spoken LLC podcast. Please subscribe on Spotify, Apple Podcasts, or wherever you listen. Remember to connect with us. Follow, comment, subscribe, share, be a guest. Visit us at uniquelyspokenllc.com/podcast. That's UNIQUELESPOKENLC.com/podcast. Or if you are a viewer, scan our QR code. Please remember to stay informed, stay empowered, and keep the conversation going. We love hearing from you, and we'll see you next week.